Hello, good afternoon. My name is Ed Coates and I'm one of the consultants at the Fertility Partnership, and I work at Oxford Fertility. And I wanted to spend just 15 minutes of your time talking to you about a very important topic which has been very close to my heart over the last 5 years, an area I've spent a lot of time looking at closely, and particularly in Oxford here we're very interested in embryo transfer. It's quite an under-discussed area, but such an important part of the patient journey. And quite often patients will go all the way through the IVF cycle and get as far as the embryo transfer. And for some people, it's a very happy moment, but for some people, I've heard the comments of it was a bit of an anticlimax, having huge expectations about what the embryo transfer day involved, and then having to disappear afterwards and wait for 2 weeks for the outcome. Now, the reality of embryo transfer is it's one piece of a huge jigsaw. And I think one of the things that we have to look carefully at as clinicians is every single piece of that jigsaw when we're looking at why an IVF cycle works. And I like to call it the IVF puzzle. And when you look at the many factors that impact on an IVF cycle and why it may not work, I think embryo transfer is important. There are many factors to consider. We have to consider the embryo. We all know that the embryo is really crucial to overall success. And that's why as you get older, we see success rates will fall as egg age increases. And there are many factors that impact on the overall quality of an embryo. But what else apart from the embryo, which we're constantly told is the important factor for a successful IVF cycle, do we have to consider? There's a lot spoken about the endometrial receptivity nowadays, and the endometrium seems to be so important in terms of that very delicate interaction between an embryo and an implant and a successful implantation. The womb, the uterus, and the immune system are all other factors that we have to consider. Fibroids, polyps, and blood factors and the immune system have all been discussed in great detail. But then there's this huge area of the IVF cycle, which I don't think is discussed in enough detail. It's an area I spent a long time researching, and it's the embryo transfer. But surely an embryo transfer is just very simple. That's what most people say to me. And therefore, is it actually scientific, putting an embryo back in the uterus? Or is it just something which is an art, which takes a long time to learn to do? And I think my personal view is, curiously, that both of these areas are probably, in fact, true. When we look at the actual procedure of replacing an embryo into the womb, we can see a really nice diagrammatic here of what's actually going on. The patient will lie on their back generally in what we call the lithotomy position. That usually involves having the legs lying over some stirrups with the vagina exposed, so that very much like when a smear test is performed, we can get a full 360-degree view of the cervix with a speculum. The cervix will, in most cases, usually be cleaned with saline or water. And then at that point, once you have a clear view of the cervix, this is where we see many differences. But in general, the process of checking the name of the patient, loading the embryos into the correct well in the incubator, and preparing for the transfer begins. Now, different clinics will approach this in different ways, and we've seen this across many different studies in the literature. Some people will load the embryo directly into the catheter, and some people will load an initial catheter, a coaxial tiny catheter through the cervix first, to create a passageway for the embryos themselves when they're loaded into a different catheter. So there's different techniques to putting embryos back. But essentially, with a small push of a syringe, an embryo is released, or 2 embryos are released into the womb with just a momentary push of a syringe. Sounds very basic. And then after that, the syringe is checked and the catheter is checked to make sure that the embryo has come out of the catheter successfully. Here we have a nice diagrammatic, a nice video I want to show you of a very easy transfer that's going on in the embryo transfer room. We have ultrasound guidance here, so you can see what's happening. If you follow from the right side of your screen, so you can see an embryo transfer catheter making its way through the cervix, through the external part of the cervix to the internal part of the cervix, where we meet the womb. And there you can see the catheter now gently settling into the middle area of the womb, and a small push of the syringe. If you watch carefully, you'll see a small flash And this may be something that many of you will be familiar with if you've had embryo transfers. But for those of you that haven't, this moment is the moment the embryos return to the womb. It's a nice moment when you see the pictures, but with a full bladder and a speculum in the vagina, it certainly isn't comfortable. And I've had many patients say it really isn't what they expected. But this is essentially how we replace, after all those weeks and months of collecting eggs, creating embryos, injections and procedures in theatre, we finally get to the embryo transfer. And this, I would have to say, having done many hundreds of embryo transfers, is in fact a very easy transfer. But they don't all look like this. So what actual factors affect the success after an embryo transfer? Well, we know, as we've said before, the actual grade of the embryo quality will be very important to whether an embryo implants, the number of embryos, the stage of their development. We also know that the different types of catheter that we will use in clinics can impact on outcome. Different loading media, which will be used at the end of the catheter. And in some clinics, there will be an attempt to look to see whether an embryo transfer will be easy or difficult. And that's an area I want to talk a little bit about today. It's an area that's I think, quite important. But really, during the procedure, does it matter how the patient lies? Should they lie at a specific angle? Does taking pain relief or acupuncture help with the outcome of your embryo transfer? Does it actually matter whether you watch your embryo transfer under an ultrasound machine with a guidance and a nice picture to see where that embryo is going? Do you need to fill your bladder? Is bladder filling important? And actually, we all know that the pessaries which patients take prior to preparing the endometrial window for implantation can create a lot of mucus in the vagina. Is the mucus in the vagina harmful? And actually, does it matter whether the procedure is easy or difficult? What's difficult? What does it mean to be difficult? And is there an ideal place to actually place that embryo? Does it matter if the embryo transfer takes 10 seconds or 60 seconds? And how long should you leave the catheter in the womb for? And I think these are all areas which are really important in actually, when you break down that very simple video I've shown you of putting an embryo back in the womb, which probably do impact on overall success. But I want to focus a little bit on difficult versus easy, if I may. So what is a difficult transfer? If I ask many of you, did you have an easy or a difficult egg collection? I'd get 100 different responses. And it's a very subjective thing. And interestingly, there's no universally agreed definition of what a difficult embryo transfer actually means. People have looked at this in the literature, and I spent, in fact, 3 hard years of research in an area I'm quite excited about. I think it's a huge area still with a lot of more potential for research to look at the study data on this. But we still don't have no universally agreed definition of what is a difficult transfer. The one definition that I could really surmise from all of my reading is that something that's difficult is something that's not easy. Now that may seem very simple, but if something's easy, it's easy and it goes very quickly. If something's difficult, then the lack of resistance a catheter has is very straightforward. And we've all, as doctors and nurses and clinicians who do embryo transfers, know when a transfer has been straightforward. But the moment the catheter actually meets any resistance at all, then additional maneuvers are required to actually thread that very, very soft, fine catheter through the cervix. And I think an easy transfer is one where there's no resistance, and a difficult transfer is everything else. But then that needs further clarification. So how do we record difficult embryo transfers? Again, it's very subjective, and this is exactly what we found when we did our research in the fertility partnership. We rely heavily on clinicians' interpretation of how easy it was to thread the catheter through the cervix. We asked people to write things down, but as I found with my research, we have incredibly different descriptions of this throughout the country, through different clinics, and different approaches to this, such an important step in an IVF cycle. We can use ultrasound, and you've seen a very nice record there with that ultrasound image of an embryo transfer that was straightforward. But should we be recording all ultrasounds to guide us, to give us a record? So ultrasound videos can be helpful. But when you look at all of the literature, there's been over 250 peer-reviewed papers in this area. But what we found from that is that we're seeing all sorts of different approaches to research in this area. and we're seeing all sorts of different outcomes from research, often with conflicting results. And so the data is very homogeneous. We're seeing all sorts of different numbers of embryos having gone back historically into the womb when people are looking at embryo transfer difficulty, both at the cleavage stage and the blastocyst stage. And increasingly, more and more clinics are now putting embryos back at the blastocyst stage as culture and lab techniques improve. But there are variable definitions of embryo transfer throughout the literature, so it makes it a very, very hard topic to study. But I personally think IVF success is affected by how difficult your embryo transfer is, and I've shown that with some of my early research. And multiple factors can affect the ease of a transfer. This was a lovely paper that came out towards the end of 2017, which said exactly what we'd be looking at, is that how do you define a difficult transfer? And this is an American study that looked at over 7,000 embryo transfers. And they showed that with successive maneuvers that are used during an embryo transfer process, we actually see a fall in clinical pregnancy rates. So there is something happening here, and it's being scientifically shown. The nice thing about this is it used a very similar grading system to one that we were looking at the time, and trying to develop and to create as potentially a national approach to grading embryo transfer. But there were some criticisms of the study. It was retrospective. It was looking back at data rather than prospectively. It was combining both mixed and frozen, fresh and frozen embryo cycles, which we all know have different impacts on implantation. And on average, 1 to 2, almost 2 embryos were replaced throughout these cycles. And I think increasingly more now we're looking at single embryo transfer. And I think from my perspective, there is definitely a lot of evidence out there that embryo transfer is impacting on what we're doing, but we need even more robust scientific results to make us all accountable in terms of what we're doing when we take the embryo out of the incubator and return it to the womb. So from my personal view, I think the factors that are associated with a difficult embryo transfer, and those of you that have had difficult embryo transfer may remember the extra stress that this adds to your experience of having an embryo replaced. I think when we get resistance to the catheter, that's important. We know that all cervixes are not uniform, and my job and all my colleagues would be easy if, in fact, the cervix was just a straight passage for us to thread a catheter through. It could probably be done with robotics if this were the case. But actually, the cervix does stenose, and it does narrow, and it convolutes as well. So it's different in all of our bodies. The angle that the uterus is pointing at is probably important. If you've got to send a catheter around a curve, around a bend, a sort of a 90-degree bend, that's probably going to be more difficult to do than a straight line. So we call that the uterocervical angle, and the angle that the cervix makes with the womb itself does appear to be quite important. The time to transfer, we certainly know, does impact, and many labs up and down the country, certainly in the UK and abroad, will in fact not load the embryo into the catheter until we're absolutely certain that we are in the cervix and we've found the passage through to the womb. This is called the double loading technique, and that means that the embryo only ever comes out of the incubator once the cervix has clearly been navigated. And I think this certainly increases the chances of an easy transfer, reduces the time to transfer of the embryos, and it reduces the chance of the embryos cooling, which we all know has an impact on them. Bladder filling, I do think, is important. We've certainly, it's an area that requires more research. In the study and the work that we did in Nottingham and with the fertility partnership, we didn't find it to be in itself, in isolation, important, but bladder filling is done alongside ultrasound guidance in many clinics to give you a nice view on ultrasound of the womb. And so possibly it's quite hard to tease out between the ultrasound guidance and the bladder filling, which is the most important part of this. Blood on the catheter, we've seen from research, does seem to be important, and unloading the embryos also can be quite important too. Many of you, although very rarely embryos get unloaded from the catheter, this does seem to increase the cooling that goes on. Tenaculum use, which is a grasper that we use to put onto the cervix, is something that I was always taught never to try and do. We think can increase the release of cytokines and vasoactive chemicals around the time of a transfer, increasing the contractions of the womb. So we try to avoid this if we can. So why is difficulty important? I think patients and clinicians care about difficult transfer. It adds stress to an already stressful situation. And we know that between 2 to 18% of embryo transfers are difficult. And we also know that it reduces pregnancy rates. It is difficult to predict, however, when a patient is going to have a difficult transfer. And it does have an impact. It prolongs the transfer time. We can potentially be exposing the embryo to undesirable conditions depending on how you've loaded the embryos into the catheter. The catheter becomes distorted. And all sorts of other changes could be going on in the tip of the catheter there, which impact on that precious embryo as we return it to the womb. But here's a number of studies that have looked at this, and we know that the type of catheter, soft versus rigid, soft catheters have an advantage. Ultrasound guidance appears to be really helpful. Where we put the embryo in the womb is important. As I've said already, bladder filling, is this important? We're not quite sure. Does the type of media we actually use make an impact on clinical pregnancy rates with embryo transfer? Possibly. Unfortunately, we've not shown yet that acupuncture, cleaning the mucus from the cervix, or lying down for half an hour, for example, after your embryo transfer makes any difference to your success rates. So we have got some good scientific basis for some of the things that we talk about, but there's still so much more in this area. But ultimately, the question I said at the beginning to all of you was, is this an art or is it a science? And I think it's a bit of both. I think science is key to trying to guide us in terms of the way we do things. But ultimately, there is definitely technique involved in gently replacing an embryo into the womb. And so having an operator who's doing embryo transfers regularly, frequently, as we all know, doctor, nurse, anybody in the clinic of any level, it's the person doing them the most regularly who will be the most dexterous and the most skilled, we would hope. And so we always measure these internally within our clinics to look at it. So my personal view is that I think it's both an art and a science, but there's a lot more work that we can be doing on the science. So I hope you found that a useful talk with embryo transfer. I think it's a really under-researched topic, and I think it's an area that we've got lots more exciting things happening here at Oxford Fertility with regards to projects that we're looking at to try and improve that 1 or 2% you might get from additional improvement with an embryo transfer may make that extra baby for a couple. And so we are always striving with our research here in Oxford, but this is particularly a topic which we're very interested in. And we have a lot of experience. So I hope you found that useful. It's not a topic that often talked about, but please happy to answer any questions.